Ladies and gentlemen, a very warm welcome to day 2 of this 3-day conference. Day 2 is dedicated to the discussion on lung cancer. And as I stated yesterday, we have a very innovative agenda, and we are very cognizant of the fact that many webinars have happened over the last 4 to 6 months. And not to lend a repetition to it, we have something very unique. We will be talking about the issues emanating from the day-to-day discussions. And I have the privilege of sharing with you that yesterday we had more than 750 attendees who logged in on both the platforms, the YouTube as well as the attendee login, and the total number of registrations, cumulative registrations for the 3 days till now are about 1,200, and I do hope that this will only get better. Without further ado, I have the privilege of introducing the program director for today's program, Dr. Jyoti Bhadwa, who's a senior medical oncologist and a director in the Department of Medical Oncology and Hematology at the Medanta Medicity. She actually is in charge of the head and neck, CNS, and thoracic oncology. I hand over the proceedings to Dr. Jyoti Bhadwa. Dr. Jyoti, please.
Thank you, sir. Good evening, everyone. And let me introduce today's. Just give me a moment. I have.
Madam, your voice is slow. Yes.
Just give me a moment. Yeah. Am I audible now?
No.
Sir, am I audible?
Yes, you are audible. Yes.
Is it clear?
Very well. Very well. Please go ahead.
Everyone, and welcome you all to this day 2 of the Oncology Update meeting. And we look forward to exciting and fruitful discussions on lung cancer, its various aspects. Actually, the field of lung cancer treatment has evolved really rapidly in past decade, and especially so in past 5 years. And we have realized that it's no longer a single disease, and it's very heterogeneous. And we are also surprised, as well as in fact, pleasantly surprised to have so many options available to us now. And you'll be surprised to learn that in this year itself, even though it's the month of August and lot many more months to still go on, we have had these many new US FDA approvals for this single disease entity. So with this brief introduction, let me invite our first speaker, and that is Dr. Amit Verma. He is the consultant molecular oncologist and cancer geneticist at Max Hospital, Sake, and he's also in charge of the personalized cancer medicine there. So I welcome Dr. Amit Verma to deliver his talk.
Hi everybody. Am I audible?
Yes, sir.
Yes.
Okay, perfect. So thank you, Dr. Vad, and thank you, Dr. Wadhwa, for inviting me for this talk. And I think right now this talk is very important because we are right now seeing a lot of change in the paradigm, the way we are investigating the patients actually. And definitely the treatment has dramatically changed over a few years. So my topic given to me was the sequential biomarkers testing versus the upfront NGS in metastatic non-small cell lung cancer. So currently, what we are doing on in our clinical practice, routine clinical practice, is that we go for the single biomarkers, EGFR, ALK, ROS, and PD-L1. So these are the commonest 4 biomarkers what we normally go for. But there are a lot of challenges with this approach. Definitely, it is a cost-effective approach, but a lot of challenges. And what we understand that sequential testing leads to high tissue depletion. And by the end of fourth test, 50% of the tissues are depleted. So there is nothing for us to investigate further. So that's a major challenge. And as per the NCCN guidelines, we are supposed to investigate few more biomarkers which are not routinely available in the clinical practice. So in the clinical laboratories. So for us, it becomes very difficult to just limit ourselves to just EGFR, L-cross, and maximum PD-L1. And the important aspect, what is the wastage in time. So sometimes there is practically the lab takes their own sweet time to do sequential testing. And even the guidelines are recommending the broad molecular testing technique, including the CAP, and which can not only pick up the EGFR, but also the other mutations like BRAF, KRAS, HER2/neu, MET, and copy number alterations of MET and HER2/neu, and rearrangement. So if we go with the sequential aspect, we may not be able to pick up all the different classes of mutations in all the different genetic genes. And even in the ASCO educational book, for situations when we have a limited samples or the tissue is very limited, the NGS is recommended. So we have a robust support coming from the pathology-based guidelines and the clinical guidelines to go for the broad molecular-based techniques. So if you use a single sequential biomarker, even if you really want to do it, even with the gold standard like FISH, they can miss 35% of the L translocation. So that's a big cohort which we are missing. And if you go with the NGS-based approach, which are currently available, and which is with the hotspot approach, you may still miss 17% of the EGFR cases. So definitely, these things can be overcome by the comprehensive genomic profiling, which is a higher version of NGS, where all the introns and exons and intron-exon boundaries of the whole gene is being analyzed. So this is a study which was published by Shrock, and which talks about that patients with EGFR 19 deletions may, which were negative, were able to find more mutations in the EGFR, and then they have some benefit with the EGFR inhibitors. So this is again a point which we just discussed, that the standard of care EGFR testing sometimes may miss, and which we need to investigate further. In terms of doing L translocation by FISH or by HC, which is a routine clinical practice, but we are not able to find out the partners of the L translocations like EML4, TFG, or the variants of EML4I for that matter. V1 is the variant 1 and V3. These are two important variants which are quite common. And variant 1 is more sensitive to crizotinib, and variant 3 is less sensitive or less responsive to crizotinib. So this information has some clinical utility, which is not being evaluated by any of the single sequential biomarker approach, but can be deciphered by the NGS, comprehensive NGS approach. So there is an added clinical value of using NGS-based approach in treatment of lung cancer. Beyond EGFR, as just mentioned, ALK also can be picked up by NGS more. And patients who are treated based on the NGS-based approach, there may be up to 2/3 patients which were initially negative found to have complete or partial response based on the positivity picked up by the NGS. So there is not only a diagnostic benefit, but a clinical benefit which is quantifiable, and patients may get a more benefit out of it. Similarly, even for the ALK translocations, patients who were negative for FISH eventually found out to be positive on NGS. Patients do respond to crizotinib. So NGS approach can not only pick up, but it is a robust technique where you can rely upon and be confident that yes, it is a predictive biomarker of response in the clinical practice. So let's talk about the real world practice. This is data coming from Medicine et al., where they have analyzed almost 5,000 patients who have underwent a tissue-based NGS and a liquid-based NGS using comprehensive genomic profiling. And what they found that approximately 22%, that 1 in 5, may have a targetable genomic alteration. And once you treat them, you may see good responses in the liquid biopsies, that is the purple, and the red is tissue. And there are few scenarios where you may find very good correlation in terms of responses in up to 100% in few mutations. But interestingly, the liquid biopsy can pick up BRAF, HER2 acting mutations, and other MET exon mutations, which can be again targetable, just besides the tissue. And this is the approach where you can not only go beyond EGFR, ALK, and ROS, but the other actionable targets with quite a good clinical utility. So the guidelines recognize the usefulness of the liquid biopsy, especially at the time of diagnosis, when we need a tumor molecular profiling and the tissue is limited, or the patient is unfit for sampling, and there is a less tissue. So practically speaking, the liquid biopsy is based on the NGS. There is no way that anybody can do a single test-based liquid biopsy. So once you do a liquid biopsy, not only you get information about the multiple genes, but some additional information like tumor mutation burden can also be picked up on liquid biopsies. So we'll discuss in the next slide actually. So liquid biopsy can complement the tissue-based profiling, and both of them are NGS-based. So combining them is a good idea. There's a lot of concordance, but definitely it can give you some additional information which is not picked up by the tissue biopsies. So the new treatment options in the lung cancers is driven by the biomarkers. And if we see beyond EGFR, ALK, and ROS, there is an important mutation, MET mutation, which is up to 3%, and RET mutation up to 2%, where we have a lot of new drugs coming up in the red column and the MET column. And even the MEK inhibitors are also there, but it's less than 1%. So important mutations which are almost equal to the ROS1 alteration frequency, MET and RET, should be investigated, and the sequential biomarker approach will not be able to pick up these alterations. So if we see the new Geometry 1 trial, which talks about the MET exon mutations and treating the patient with capmatinib, what they have found that the patients who are treatment naive, they respond beautifully with the objective response rate of 68%. Vis-a-vis a patient who have treated with 2 or 3 lines, the response rate drops to 40%. So the take home is, early on we investigate the patient with all these rare mutations, you may see a better outcome in your treatment response. That is the take home for this slide. And this is again the tepotinib, which is again a MET exon skipping mutation inhibitor with a response rate of almost like 89% over here, but the average response rate was up to 50% actually. And this led to the approval in Japan, but you can see quite a good, beautiful response with the available drug. Again, selpercatinib, LOXO 292, which is a RET fusion inhibitor, can also show response to the RET fusion genes. But interestingly, all these alterations have been tried in treatment naive patients actually. And so that is the benefit what you get starting early on. So again, with the trial, phase 1, phase 2 arrow trial, perlacitinib can also be used to inhibit the RET kinase inhibitor with quite a good response rate. And again, people are looking for the treatment naive population in these scenarios. So let's talk about the new biomarkers beyond the genomic biomarkers. That is the PD-L1, which is a single biomarker which has to be done separately. But PD-L1 definitely favors a response to the checkpoint inhibitors, but it is not an absolute association. So we'll see in the next slide that the patients who have high PD-L1, high TMB, definitely show responses to monotherapy of the PD-L1 or the combination therapy with PD-L1 CTLA4. But patients who have low PD-L1 or less PD-L1 expression with high TMB still shows a response to all these immunotherapy. So TMB definitely is a complementary biomarker for response to immunotherapy. and this TMB information can be gathered by NGS only. So this is the data talking about the utility of the blood-based TMB on the liquid biopsy, where patients are being offered atezolizumab, and this is the popular in the OAK study where they have shown responses. And the cutoff used was the blood-based TMB was more than 16 mutation per megabase. Similarly, in the MYSTIC phase 3 trial, the blood-based TMB showed benefit using durvalumab, but the TMB cutoff used was more than 20. Again, combination of pembro plus minus chemotherapy in this trial showed that the plasma TMB can serve as a biomarker with the cutoff of 16. So this is the data coming from Max Hospital. This is my data which I have analyzed and collated, where the routine clinical practice, this is a case study of almost like 35 cases. Routine clinical practice, the EGFR cross is approximately cumulative of 46%. But when you use the NGS approach, you may pick up additional percentage of targetable alterations, and your 46% goes up to 70%. And these are the NCCN guidelines recommended treatment. If you go beyond the NCCN guidelines, you may get actionability in almost like 97% of the total patients, but these are non-FDA approved approaches actually. So this is the summary where the single platform is compared with the NGS platform, EGFR ALK, and so you can see the MET, BRAF, RET, ERBB2, and these are all additional information which was picked up by the NGS platform. So this is a case study where a 56-year-old gentleman with a metastatic lung cancer who was found to have EGFR mutation del19 deletion with a single sequential test had a rapid progression on allortinib, thereafter afatinib, and he had P790m on progression, was on osimertinib. But the patient was investigated using NGS in a retrospect, and what we found that the patient not only had the exon 19 deletion, but also had ERBB2 amplification, which was the explanation why the patient was not behaving as expected on the first generation or second generation or third generation TKIs. So sometimes beyond the targetable, actionable targets, what we are looking at, you sometimes get more information on the inherent responses or inherent mechanism of resistance which can be present, you can say, together in the initial steps. So this information is sometimes very helpful. So to summarize my discussion, using NGS will pick up several biomarkers at once. It avoids tissue exhaustion. It saves time. And with the new advent of so many targetable drugs available, so we are obliged to find the best answers for the patients before we plan the treatment for them. With that, I thank you all for your kind attention.
Thank you, Dr. Amit. That was really very, very informative. And I would request the participants to post their questions now. We have time to take a few questions. So for the benefit of our DNB residents in particular, Dr. Amit, could you please sum up as to what you are recommending? Say a case of lung cancer, and let's restrict to non-small cell lung cancer. What biomarkers are you recommending upfront, and which sample, whether tissue or blood, and which method?
So
you could meanwhile answer this. Yes.
So if there is no cost constraint, I would go with the biopsy is available. I would have to go with the tissue-based test, a comprehensive NGS, along with tissue IHC of PDL1. So these are two important things which I will go upfront if I have the access to tissue and there is no issue in affordability. If there is no access to tissue, I would go with the blood-based molecular testing. Blood-based molecular testing, which will give me a lot of information on the TMB status and the genomic alterations. That will be my second tier of investigation if the first is not available. The third, if the patient cannot afford, definitely we have to go with the sequential biomarker. For that case, I would be going for EGFR, ALK, and ROS. I would refer myself to PD-L1 because again, cost becomes a constraint for that patient who cannot afford NGS. So, but if the patient can afford NGS for whatever matter, then PD-L1 has to be done. So, three-tier approach for a patient of three different strata.
Jyoti, can I make a comment? This is Hemant Malhotra from Jaipur.
Good evening, sir.
Good evening, sir.
Very good evening, Amit. Very nice presentation, and I think your last sentence was very important and relevant. I have seen so many patients in which all the patient's money is expended on NGS and whole genome sequencing and you know what, and the patient doesn't have any money for even generic tyrosine kinase inhibitors. So I think each one of us has that responsibility to keep that in mind. Thank you.
Thank you, sir. So we have a question from Dr. Yama. He is asking, are there errors possible in NGS? Those errors, will they affect the detection rate or the quality of detection?
So it's a very good question, and various errors can happen. When we talk about the pre-analytical errors, it is quite possible, and then you may have false negative rates. You may not be able to pick up the information what was there. So that is one possibility. The second possibility could be the way the algorithms of NGS are being read. So sometimes if the alignment is not done with the reference genes properly, you may see the location of the mutation at a different site, which may be misleading and you may not act upon it. That is second. Sometimes the NGS-based approach is not able to pick up all classes of alterations, which include the translocations and copy number variations, but they are able to pick up the point mutation. So you have to be very cautious in terms of what kind of reporting they are doing actually. That is a third possibility. And the fourth possibility is that the types of genes what they're analyzing, are they covering up your whole panel of the expected panel what we're talking about. The hotspots sometimes focus on the few areas, not the whole gene, the all important exons. In that case, we sometimes miss them. So these are the technical limitations which you may have false negative. In terms of false positive, we do not see false positive in NGS that much. But again, it may be a bioinformatics error which can lead to false positive scenarios, and there could be ambiguity or because of the heterogeneity what we see. So sometimes it is better to go with the mutation allele frequency to see whether you are picking very minor clones which may be misleading, and you may just act on those minor clones and you may not see any responses as expected. On the other hand, the tissue-based sequential approaches are less sensitive and they are able to pick up the major clones primarily. So you may see more clinical correlation while acting on them. So again, so we have to see both things together before making any judgments.
Dr. Ved, sir, you wanted to make a comment?
Yeah, Amit, my concern is about the turnaround time as well. You know, you have a patient where there is sometimes an urgency to start the treatment. And then within 24 hours, you can get the PD-L1, you can get the ALK, and if you have the RT-PCR in-house, you can get the EGFR within 48 hours, you know. And how do you, if you send it for a comprehensive genomic sequencing, the turnaround time is quite long.
So the point is well taken, sir. Turnaround time is definitely longer than the sequential biomarker because of the easy access in-house access. But you have to weigh the clinical condition. If you have the window where you can manage the patient, I think it's worth going with the comprehensive genome profiling. And if the patient needs immediate attention, I think the call is all at the physician discretion actually.
Dr. Hemant, sir, you had a question too?
Yeah, Amit, suppose you get a comprehensive genomic profiling on a tumor and it throws up 4 or 5 mutations and you have targetable drugs for all those 4 or 5 mutations. How do you decide which is the driver mutation and which targeted treatment do you start first?
So this is the limitation of the overwhelming information what we come while doing the CGPs or comprehensive filing. So I personally recommend that if you have the known driver mutations, which includes the EGFR, ALK or ROS, you should target them. But if you have a complex picture when you have multiple genes to be targeted, I think in that case, a molecular tumor board helps us out defining what is the what rationale we have to follow. But definitely with this complex information, if there is a case, you should not expect the responses what you normally expect with a single biomarker thing, because you may find a lot of resistance immediately. The drug starts failing immediately. And sometimes the complexity can be deciphered or made ease by getting more information. You can ask the lab to offer us the mutation allele frequency. If the one which is a driver mutation and a higher mutation allele frequency, I think that is a logical thing to target that, and you may see a better control of the disease. That's another approach.
Dr. Amit, in your experience, how often have you encountered such a scenario wherein you see possible drugs?
Yeah, so even in the single sequential biomarkers, we have seen complex reports which include EGFR with ALK and sometimes EGFR with ROS and sometimes complex pictures. And in the NGS, definitely we encounter one or two alterations which may be targetable, especially if you talk about the PIK3CA mutation, which is quite a prevalent mutation in lung cancer as well. So up to 20% to 25%, you may hit that alterations if you investigate them. So, but in terms of EGFR amplification and EGFR mutations, and along with the HER2 new mutations, sometimes you see this quite often actually. But we rarely see alterations like ALK alterations with the EGFR mutations or ROS alterations with the EGFR. So they are practically mutually exclusive, but you may see rare exceptions actually. So, but for all practical purposes, it gives you a very simple answer, straightforward. Yes, this is the key mutation I was looking at, and I got the answer. I should start the treatment.
Right. Thank you for that answer. And one more question from Dr. Bhuvan. Is it possible to detect on liquid biopsy P790m mutation post osimertinib?
Yeah, the answer is yes. So if you talk about the liquid biopsy offered by the foundation, they have 70 genes, which includes the EGFR and all the alterations, so you can easily pick up. And in terms of whether it is cis or trans, it may be difficult, but yes, you may get some answers. Yeah.
Right. So if there are no more questions, I thank Dr. Amit once again. Thank you, Dr. Amit.
Thank you.
The next speaker was to be Dr. Kumar Prabhash from Tata Memorial Hospital. However, due to unavoidable circumstances, he could not make it today. So I'll make a small effort to fill in the space. I thought since COVID pandemic is ongoing, it's very important and relevant to devote next, say, 5 or 10 minutes to the importance of being aware about the COVID-19 and lung cancer. So we know that...
Jyoti, can I interrupt? Your audio is very, very faint. Can you speak louder or maybe closer to the mic? Thank you.
Is it better now, sir?
Little better now, but you'll have to speak up. I know it will be difficult, but we can barely hear you.
Oh, that's very strange. Can we check the settings? Sir, give me a second. Organ affected by COVID-19, and we are dealing with lung cancer. So the patients are obviously at high risk of complications, either directly or indirectly. And while treating a patient with lung cancer, we have to balance this risk of COVID-19 against the risk of the disease progression. So I have taken into consideration the ESMO guidelines, the NCCN guidelines, and the guidelines published by ASCO in the Lancet this year in April. The ASCO has come out with a tiered approach in dealing with lung cancer patients during the COVID-19 pandemic. And what it says is that we must prioritize our patients into three categories: high priority patients, medium priority, and low priority. So lung cancer patients will get qualified as high priority patients if their condition is immediately life-threatening, if they are clinically unstable, and if the magnitude of benefit qualifies the intervention as of high priority, leading to significant improvement not only in survival but also in quality of life. Now the patient's outpatient visits also need prioritization. So the patients visiting our OPD with a new diagnosis or suspicion of invasive lung cancer by being symptomatic with dyspnea, pain, hemoptysis, or having a suspicion of clinical stage 2, 3, or 4, and requiring visits for treatment of lung cancer are put in the high priority category. Similarly, we have to prioritize the patients for imaging as well. So the patients with significant respiratory symptoms attributed to lung cancer, patients requiring the staging workup for lung cancer, patients who have biopsies required for suspicious nodules or lung masses also are put in the high priority category. And if we have to evaluate a patient in terms of response assessment while he is on active treatment, that patient is also of high priority. Now, as medical oncologists, we need to prioritize patients based on their stage also. So patients with early stage lung cancer, if they have been on or they have to be planned for concomitant chemoradiotherapy for small cell lung cancer limited stage disease, or if they are on neoadjuvant chemotherapy for stage 2 disease, or they need adjuvant chemotherapy for stage 3 disease or for stage 2B disease, they need to be put in the high priority category. And also if they need growth factor support for prevention of febrile neutropenia, they are high priority patients. Patients with locally advanced lung cancer, if they need concomitant chemoradiation, again for small cell lung cancer, they are high priority. Those requiring chemoradiation for stage 3 non-small cell lung cancer, or those starting consolidation immunotherapy with durvalumab, they are high priority. And patients with stage 3 NSCLC requiring neoadjuvant chemotherapy are high priority patients. Patients with stage 4 lung cancer are also prioritized, and they are high priority if they need first line treatment with either chemotherapy or immunotherapy or TKIs or a combination, if they need to be started on second line treatment with either chemotherapy or immuno-oncology drug, if they need to be started on second line TKI, and also we have the liberty to modify the treatment schedule, and I'll come to that in a bit. Now we have to keep in mind that all these patients have to be emphasized the importance of following the preventive measures with the use of face masks, the PPEs. We have to space the chairs in the outpatient clinic area and also in the daycare center. Telemedicine has to be utilized as much as possible, and even tumor boards are preferred to be held via teleconferencing. Now, the intent of the treatment has to be defined in the beginning, whether it's curative or palliative. If it's curative, the treatment should not be interrupted because the outcome will depend on the treatment schedule. Now, sometimes neoadjuvant chemotherapy could also be considered in the beginning to get away with adjuvant therapies whenever feasible. And the growth factors have to be used judiciously and more liberally in COVID-19 scenario. Now, if it's metastatic lung cancer, we could consider treatment interval prolongations or deferring the dose as is deemed right. Also, oral therapies can be preferred over intravenous chemotherapies whenever appropriate, such as use of oral etoposide or say temozolomide, etc. Now, immunotherapy requires more intense infusion therapies and more frequent visits, and there are recommendations now for extended interval immunotherapy. We can also extend the interval of supportive drugs like zoledronic acid, giving it every 3 months instead of every month. Coming to immunotherapy interval alterations, I have listed here the approved interval alterations. So atezolizumab can be given in 1680 milligram dose every 4 weeks in small cell lung cancer. Durvalumab has recently been approved in a fixed dose of 1500 milligrams every 4 weeks for small cell lung cancer. Pembrolizumab, the interval can be increased to 6 weeks by doubling the dose to 400 milligrams. And similarly, nivolumab can also be given at increased interval of 4 weeks. So while treating these patients, it's very important to therefore keep all these things in mind and be careful of not only the risk of COVID, but also of lung cancer disease progression. So I would request the experience sharing from other senior medical oncologists at their center as regards COVID-19 and lung cancer. Maybe we could start with Dr. G S Bhattacharya. Can we have your experience, sir? Dr. G S, sir? Dr. Hemant, can we hear your experience?
Yeah, I think Jyoti, you made some good points, and I think the most confusing thing for me in a patient who has lung malignancy and also a COVID infection is to decide on the chest X-ray and on the CT scan, like how much is it because of the lung lesion and how much is it because of the viral infection. So that actually is a huge problem, and it is still not sorted out in literature also, that what you can label to COVID, because the treatment of COVID is very proportionate to the intensity, and the intervention is very proportionate to how much of lung damage you have. So that is an issue. One more issue which I think is important, which we face on a daily basis, is when you're doing the triage of a patient, the patient has cough, the patient sometimes has lower respiratory bacterial infection, fever. The patient also has a low SpO2 because of his lung malignancy. Then again, when he is entering your OPD and there is a technician outside doing the triage, it is difficult to then decide whether this patient should go to the COVID OPD or should he be permitted entry into the oncology OPD. So those are my thoughts.
Right.
Can I make my comments?
Yes, sir, please. Dr. G.
There are a couple of issues that I would like to point out. Hemant has rightly pointed out a few of them. That one, lung cancer does present with cough and fever. So that becomes a attitude of triaging the patient to certain things. Now, assume that a patient is COVID negative and you have started treatment. My worry is with with immunotherapy causing a hyperprogression or even causing a pseudo hyperprogression, which on a scan may look like an infective issue, and at the same time we have the COVID raging, and the fear psychosis, which is also there, that 30% of COVID patients would be negative for the PCR antigen. So that becomes a major issue. The other issue that I can tell you personally, that the fear that people had of immunotherapy increasing the risk of COVID. My own experience with basically immunotherapy is basically based on the use of nivolumab, but quite a few number of patients that have used them in this lung cancer issue right now. I really haven't had any problem for that. The other thing that I really want to bring forth is that, when you are treating lung cancer, If he needs the treatment, give it to him. Don't shy away because of COVID. If he doesn't need the treatment, don't over-treat him because you can run into serious trouble. And yes, be pragmatic. If it's a 4-week, you can give a drug, give it in 4 weeks. If you can give a, like I'm using cisplatinum etoposide, where I would give cisplatinum day 1 and put the etoposide by mouth for small cell carcinomas right now, rather than keeping them for 3 days in the hospital. So that's another alternative. And we know that's an accepted alternative. So we have the issues that we have to be very pragmatic and decided. But the time, Jyoti, I would say right now is, like you're taking our advice, let's collate. Like I have 3 patients who had COVID while on therapy after the second cycle. How did they fare? I had patients who came out of COVID and then we have treated and are doing well. So if we can collate our data, we actually have a reasonable number of patients, I think, so where we can put forward some sort of thing, a 1-page question, no? And then a write-up, a reasonable place for publication. I think we go a far way. Thanks, Jyoti.
Very well said, sir. Thank you very much for your experience sharing and your suggestion. We'll definitely be happy to share our experience as well. So thank you, everyone. And let's move on with the next talk. And I have the pleasure of inviting Professor Hemant Malhotra. He's a very senior medical oncologist of our country, and he's currently the head of the Department of Medical Oncology at Shri Ram Cancer Center at Mahatma Gandhi Hospital, Jaipur. And sir would be speaking about 2nd generation versus 3rd generation TKIs in first-line treatment of EGFR mutated non-small cell lung cancer. Hemant, sir, please.
Thank you very much, Jyoti. Thank you, Ashok, for this opportunity. I've taken the liberty of expanding my talk to include the 1st generation TKIs also, because for obvious reasons of cost, most of our patients land up using 1st generation TKI, so I thought it might be appropriate for us to see that. So as of today, more than 50% of patients do have a targetable biomarker, and 18% in the Western population, and maybe 10% more than this. So between 20 and 30% in our country, patients have the EGFR mutation, and that is going to be the topic of my talk today. And this is the treatment landscape for non-small cell lung cancer over the years. And you can see that targeted therapy, basically the first was the approval by the European Union of gefitinib in first line. And then you had, approval of ALK, and then the other 2nd and 3rd generation TKIs subsequently. And this is the new paradigm of treatment of our patients. If the patient has a sensitizing EGFR mutation, for first line you have gefitinib, erlotinib, afatinib, and dacomitinib. You also have osimertinib, and once there is progression, you look for mutation, and then you have osimertinib or chemotherapy in the 2nd line or in the 3rd line. So let's talk about management of these EGFR mutated patients in a little more details. First, the receptor. This is the wild type EGFR where there is no mutation in the receptor. The downstream, the dimerization of the receptor and the downstream cascading happens only if there is stimulation of the receptor by the ligand. And as contrasted to this, if there is EGFR, if the receptor is mutated, the pathway is on all the time, not even requiring the ligand, and that leads to excessive stimulation, excessive signal to the nucleus, which leads to transcription, protein synthesis, proliferation, apoptosis, and the malignancy and the propagation of the malignancy. These are anti-EGFR TKIs, 1st generation erlotinib, gefitinib, 2nd generation afatinib, dacomitinib, and 3rd generation osimertinib. And we are lucky in the sense that we have both these agents available to us since several years. We have these agents, 2nd generation, also now available. Dacomitinib is going to be launched by Pfizer very soon, and osimertinib, the 3rd generation TKI, is also available to us. And this is the comparative evaluation of the TKIs, the 1st generation over here, 2nd generation and 3rd generation. And you note that the effectivity of the drugs in our standard mutation, deletion 19, deletion 21, is much more with the 2nd and the 3rd generation TKIs. And the blood-brain penetration, which again is important because lots of these patients have brain metastasis, is much more with osimertinib and the third generation agents as compared to first and the second generation agents. We know that P790m mutation is the bad one, which happens after first and second generation TKI use. And you can see the IC50 of the various agents over here. Only osimertinib has a low IC50 against this T790m mutation. Very high IC50 for gefitinib, erlotinib, but they don't work in the patient who has these mutations. And the second generation agent. So obviously the agent of choice, if you have this mutation.
Hemant, we are losing your audio.
One of the second generation TKIs or one of the first generation
Hemant, sorry to interrupt. We are losing your audio. Can I suggest your audio would become better.
So these 6 trials, then we can see very clearly significant improvement in progression-free survival. But however, when you look significant difference in progression-free survival, 6.9 months with chemo and 11.1 months with afatinib. And if you combine the two trials, Lux Lung 3, Lux Lung 6, you can see in both the studies there is a major difference in PFS as compared to chemotherapy. And this is the overall survival. If you look at the overall population, there is no difference in overall survival, both in the Lux Lung 3 study and in the Lux Lung 6 study. But however, if you look at the subgroup analysis of these Lux Lung 3 trial, and you look at deletion 19 patients, there appears to be a survival advantage with a significant p-value. However, this survival advantage is not seen with the exon 21 mutation. So overall survival amongst patients with deletion 19 as compared to chemotherapy has been demonstrated with afatinib. Now, how does first generation TKIs compare with second generation TKIs? This is Lux Lung 7 studies, afatinib compared to gefitinib. The second generation versus the first generation. The progression-free survival is significantly better with the second generation TKI, hazard ratio of 0.7, p-value of 0.0073. However, no difference in overall survival. And again, if you look at the deletion 19 and the deletion 21, there's no difference in overall survival. The other second generation TKI, dacomitinib, this is the Archer study. This is the inclusion criteria. Dacomitinib 45 milligrams once a day compared to gefitinib. And this is the PFS Kaplan-Meier for you. Significant difference between the second generation versus the first generation. However, no survival advantage. Maybe a tiny survival advantage in the updated results presented in last year's Singapore ESMO meeting. The dacomitinib seems to be doing a little better in exon 21 mutated patients vis-a-vis exon 19 mutated patients, quite unlike afatinib. Toxicities were significant in the Archer dacomitinib study. You had SAEs in almost a quarter of patients. Treatment related were about 10%. Permanent discontinuation of drug because of AE was in about 10%, which is quite significant. Significant number of patients had to have one dose reduction in the dacomitinib arm, about 1/3 of them, and a quarter of them had to reduce the drug by to the second dose reduction. So this is like a summation of all the trials of first and second generation TKIs. You can see the gefitinib studies, the erlotinib studies, the afatinib studies, and the dacomitinib studies. And if you combine all of them together, there is a plateauing of the PFS at about 9 to 14 months. Toxicities of the agents are significant, and you can see the toxicities over here. Grade 3, grade 4 toxicities, almost half of them with erlotinib, 1/3 of them with gefitinib, and almost a half to a quarter with dacomitinib, leading to significant number of patients with discontinuation. So toxicity remains a major problem with our agents. And this is to show you toxicity again in a different way of the various TKIs. Interstitial lung disease, very common with gefitinib and osimertinib. Hepatic dysfunction with gefitinib and osimertinib. Intestinal obstruction with gefitinib and erlotinib. Skin changes with afatinib and erlotinib. Paronychia with erlotinib, with afatinib and osimertinib, and dry eyes with erlotinib. So these are the various toxicities which are common with our first, second, and third generation TKIs. So let's quickly talk about the third generation TKI. The much flaunted FLORA study. This was a head-to-head comparison, 1-to-1 randomization between osimertinib, the third generation TKI, with any one of the two first generation TKIs, gefitinib and erlotinib. Primary endpoint was PFS, secondary endpoint of response rates and overall survival, amongst others. And here you can see the progression-free survival increased from 10.2 with the first generation TKIs to 18.9 or 19 months with the osimertinib, 54% reduction in the risk of progression. Interim analysis of overall survival did seem to show a benefit to osimertinib. And even with patients who had CNS metastasis, osimertinib, the progression-free survival was almost a year and a half. And this is the forest plot for you. See, across subgroups, osimertinib did better with regards to PFS as compared to the first generation TKIs. And we had this publication in the New England Journal, January 2020, in which progression-free survival was demonstrated, a hazard ratio of 0.8 and a p-value of 0.46. And this was the first time that a tyrosine kinase inhibitor showed a distinct benefit in PFS. Subsequent treatments, all the patients, whether first, second, or third generation TKI is being used, so all the patients develop resistance sooner or later. So of course the PFS is important, 18.9 months with the third generation TKI. And subsequent treatments, almost half of the patients with the first generation TKIs required subsequent treatment. The time to first subsequent treatment was significantly more with the third generation TKI as compared to the first generation TKI. Now, the important question for most of us is, how do you sequence these TKIs? Which ones to use first? Should we use the first generation, second generation first, and on progression switch to the third generation, or should we use a best agent, osimertinib, right up front? So this is a compilation of all the trials of TKI, and they looked at how many patients, what percentage of patients got a second line TKI, and you see that about half to 1/3 of the patients did not receive any second generation TKIs. And in another study, another analysis by Wang et al., about 50% of the patients did not receive any second generation TKIs. So this does kind of convey to us that osimertinib might be the first option. Using our best agent first might be the best way to go. You can have the patient control for almost 19 months. And if the patient progresses on that, then you can think of chemotherapy or immunotherapy. And it is very possible that after a year and a half or 2 years of control, you may have another third generation or fourth generation agent, which may be able to work in patients who progress on osimertinib. You could also think of starting one of the first generation or the second generation TKIs, get a PFS of about 10 months, then use osimertinib in the second line, have a disease control of about another 10 months, and then think of chemo. But you will have to keep in mind that a large number of patients, at least 1/3, will have the P790m mutation, and about 1/3, either because of death or palliative care or deteriorating performance status, will not be candidates for the second generation TKIs. So this is my sit-at-home message slide. Ladies and gentlemen, there is proven benefit of all generations of EGFR TKIs as compared to chemotherapy, and it is pretty well established that for the patient who has a EGFR mutated driver mutation, non-small cell lung cancer, the first line of treatment should be a EGFR TKI. Survival benefit with the first and second generation TKIs, with the exception of a small benefit with afatinib in deletion 19 patients. The only conclusive survival benefit that has been seen is with osimertinib. We've already discussed the toxicities of the first, second, and third generation agents, and they remain important and must be kept in mind. Even if the patient is taking this small pill or 2 pills a day, they are producing a significant amount of upset in the body. They are inhibiting other tyrosine kinase inhibitors, so you have to know and watch out for the toxicities. The third generation agent, osimertinib, has shown significant improvement in progression-free survival over first generation agents. This benefit is also seen in patients who have CNS metastasis, and we have also demonstrated an overall survival benefit. A significant number of patients who receive TKI are not eligible to receive a second-line treatment. So this makes a case for using your best agent upfront. However, in our country, cost will remain a major factor in decision making, and I'm quite convinced that most of our patients will still continue to receive the generic first-generation tyrosine kinase inhibitor. And with that, I'd like to thank you all for this opportunity. Stay positive, stay alert, and stay safe. Thank you very much.
Thank you very much, Dr. Hemant sir, for that very comprehensive talk. I'm sure you have made the job of the panelists for our panel discussion very easy, because this topic will come back in the panel discussion. So we'll avoid taking questions right now, and we move on to the next exciting debate. The debate session is sponsored by AstraZeneca, and I have the pleasure of inviting Dr. Manish Singhal, medical oncologist from Apollo Hospital, Delhi, to speak for the motion, followed by Dr. Prashant Mehta, the medical oncologist from Asian Institute in Faridabad, to speak against the motion. So Dr. Manish Singhal first, and the topic of the debate is immunotherapy in maintenance treatment of all patients with stage 3 non-small cell lung cancer. Dr. Manish, for the motion.
Yeah, thank you, Dr. Jyoti, and thank you, organizers, for inviting me. And I'll be speaking in favor of the motion. My slides are visible?
Yes, very
Yes,
much.
okay, thank you. So the topic is immunotherapy and maintenance treatment of all unresectable stage 3 non-small cell lung cancer. So I'm taking you back to 2016 when there was a burgeoning presentations on immunotherapy in lung cancer, and it was explained as, the session was explained as earthquake of immunotherapy in lung cancer. And now, since we'll be talking about the Pacific trial, which was a double-blind placebo-controlled phase 3 study of durvalumab, I'm sure that we are going to face a tsunami. And just for the caution of my opponent, it is a tsunami hazard zone. And so as I'll be building up on this particular debate, I must warn my opponent that he's going to see a tsunami building up. And since the setting is of a debate, we'll first see what we have been able to achieve in unresectable stage 3 non-small cell lung cancer, and then whether the Pacific trial design was appropriate, whether the risk and benefit ratio was appropriate, what are the open questions, and what kind of tsunami is this. So looking back at 1980s, 1990s, we know that the median overall survival with radiotherapy alone was perhaps only a palliative treatment with hardly any curative patients. And at 5 years, the curves used to be almost touching the baseline. In 2000, about near 2000, the concurrent chemoradiotherapy, the median overall survival jumped to around 18 months. And we were seeing a few cures, and this was sitting at around 15% or so. Not that we did not try to make any headways in improving these survivals. So we tried to increase the radiotherapy doses. The RTOG 617 Lancet Oncology publication did look at that, and there was actually inferior survival by shifting radiotherapy dose from 60 gray to 74 gray. Not only this, we tried to improve on the chemotherapy. We thought that cisplatin pemetrexed in a non-small cell lung cancer adenocarcinoma will deliver better overall survival, but it was bang on similar to the control arm. Not only this, we tried using targeted therapies to improve overall survival in stage 3 unresectable cancers. The RTOG 617 used cetuximab, and again, it was a dismal, no improvement in overall survival. Not only this, there was attempts at immunotherapy. There was an immunotherapy trial called the STARTS, which targeted MUC1 immunotherapy, and the development was stopped because it didn't really improve the overall survival. And at 5 years of follow-up, you can see that the curves were almost overlapping with each other. So, was there an unmet medical need? Absolutely yes. As far as the Pacific overall survival hypothesis is concerned, it had more than 85% power to detect an overall survival with a hazard ratio of 0.73, which is in line with the disease setting, and that is exactly what was looked at in the PROCLAIM study and the RTOG study. Routinely, we see that the PFS is not very clearly read out in immuno-oncology drugs, But over here, we had an appropriate endpoint of PFS and a co-primary endpoint of overall survival. So these were quite appropriate endpoints. The study flow was a 2:1 randomization with very balanced patient groups. And what do we have in the results? The results were quite self-explainable, and these graphs well separate in time. And it looks at the progression-free survival, which is sitting at 17.4 months in the recent update, as against 5.6 months in the placebo arm. And this was of independent review committee, which was blinded. So looking at the forest plot, we can see that almost all the subgroups, be it be the EGFR, be it be the PDL1, all the subgroups seem to be favoring the addition of durvalumab, with even 95% confidence not crossing the unity line in most of the subgroups. Not only this, the overall response, the objective response rates improved, the time to death and the distant metastasis also improved from 14.6 months to 23.2 months. The PDL1 has always stood out as one of the markers which which people argue that it only benefits the PDL1 positive. But over here, even in those patients who were PDL1 less than 25%, they fared well with the addition of durvalumab. So it was for all comers, irrespective of their PDL1 expression. Looking at the risk, the discontinuation rate was not very different from placebo, and any grade treatment-related adverse events were also not very different from each other. The side effects which are of special concern, such as cough, pneumonitis, if you look at the grade 3, grade 4 side effects, it was 2.6% as against 3.4%, which was again not very severe. Hypothyroidism is quite well managed, and we know this about immuno-oncology drugs. We know that the PFS, which is often a poor readout for immune checkpoint inhibitors, was well read out in this particular study. Overall survival is definitely more robust endpoint, and what we see over here that the curves not only separate well in advance, but keep on separating as the time passes by. The median overall survival difference at 3 years overall survival curves was 44% versus 57%, which is a 13% difference, which was around 9% or 8% difference at 1 year. So the curves are not only separating, they are separating even more as the time passes by. And hazard ratio is 0.69, which is 31% reduction in the risk of death with durvalumab. Looking at the new lesions, and come to think of it, even the brain new lesions were decreased. It was 11.8% versus 6.3%. All new lesions were decreased by the addition of durvalumab, and brain is one side which is difficult to treat, and we had reduction almost 50% reduction in the risk of developing new brain metastasis. This is coming from the ADAURA study. The early overall, sorry?
Yeah, it's back now. Please continue.
Yeah. So this is coming from the early, the ADAURA study, which is the study of osimertinib, that is the best EGFR inhibitor, and overall survival curves for stage 2, stage 3A non-small cell lung cancer. This is regarding the resectable tumors, but you can see that the overall survival curves are not separating. Even with the best possible treatment for EGFR mutated tumors, with the best possible drug, the overall survival curves are not. Whereas if you can recall what overall survival curves I've showed, they seem to be coming out very well. So benefits of stage 4 are not always translated in stage 3, and over here it was well translated, and you can see that the overall survival forest plot also stands the test of time. So as far as the earthquake of CPI immunotherapy in non-small cell lung cancer is concerned, the stage 4 benefits are translated in stage 3. The open questions are, how does radiotherapy actually partner with CPI immunotherapy? There can be priming effect on by immunological cell death. It may promote danger signals. It may release new antigens, or may upregulate PD1 and PDL1 effect, and also may have some abscopal effect. So we can argue on this that what are the how do they partner with each other? But these are open questions. So after the previous tsunami of negative results, what kind of tsunami is this? We don't only have PFS benefit, but a much more weighted overall survival benefit, which is coming through so well. And so what kind of tsunami is this? It is definitely a clear knockout tsunami. And if Dr. Prashant can dose this, and if he's not able to, I've got an RX prescription for him, and that is these knockout pills, which he can definitely consume before taking on his debate. Thank you.
Thank you, Dr. Manish. Dr. Prashant, to speak against the motion. Let's see what he has to say.
So a very good evening to everyone. And thank you so much, Dr. Manish. That was such a lovely presentation. I thoroughly enjoyed listening to it. But actually, you failed to show the other side of the data, which I'll be showing everyone. And it will be an expose. So this was a paper in NEGM which Dr. Manish was so excited about, and durvalumab was deemed as the best possible treatment for this kind of a situation in patients post CCRT, irrespective of PDL1, irrespective of mutations, and IO was also administered within 42 days of the last radiotherapy, which is amazing. So what is important for IO drugs is there's too many Me Too drugs. Too many IO drugs are similar, and each company is pushing its own drug for a different indication. And not only that, they want a new biomarker for every drug and every indication. So each drug is pushing for a different biomarker and carving out their own niche in various indications, and it's such a waste of resources, funds, unnecessary increase in cost. And even with the so much of PAP assistance, these drugs are ruthlessly expensive. And whatever PAP the companies may bring in, the bottom line remains this. So look at the original paper, irrespective of PDL1, less than 25%, more than 25% unknown, there was a PFS advantage in the forest plot. You can see the hazards are favoring. And also, when we look at the post-hoc analysis, which was actually requested by EMA, in this analysis, you can very well see that the stratification was changed. And in less than 1% PDL1, the hazards were not favoring immunotherapy and not favoring durvalumab. And in this PDL1, less than 1% overall survival was not actually favoring IO arm. And please remember this number, 90 patients and 41 events. Please remember this less than 1%. I'll add on the numbers later. And then Dr. Manish will know something more about this data, the other side. So this is the EGFR subgroup also. We need to look at this. These were the mutants. They did not benefit. The EGFR mutated. Also the unknowns, they also did not benefit. You can look at the confidence intervals, they're crossing the midline and they are not, the hazards are not significantly favoring IO administration. The rest other subsets may be favoring. Also remember these numbers 29 and 132. We'll add on. So this not favoring. Now another part of the data, the baseline characteristics. I've been taught to always look at this in every paper and look at the PDL1 less than 25% and more than 25%. In durvalumab arm, the PDL1 more than 25% and more. It's unbalanced. So that's another problem with the data. So the global approval labels were there in India, in Japan, Australia, Switzerland, Malaysia, Singapore, everywhere. But EMA somehow they decided to limit durvalumab to PDL1 expressing tumors only. I thought it was pretty wise to do that. And thus I come to this conclusion that there is no role of IO in all subsets of stage 3 NSCLC, especially the PDL1 negative subgroup. We are not certain about the improvement in OS. The EGFR mutated population, we are not certain of role of IO. Al cross 1, I could not find the data in this. And also, this is a paper on ECOG PS 0 and 1 patients. How many of these our patients are always, ECOG PS 0 and 1? Some are 2 also. So if we add on the number of PDL1 less than 1%, EGFR mutated and unknown, which actually did not benefit, the hazards did not favor. These are 348 out of 476. You can calculate, Dr. Manish. Did not benefit. 73% did not benefit. So we don't know. So a very small subset actually benefited. So administration of IO post CTRT also, we don't know within 42 days how to administer. Not very easy, not very practicable. Maybe we'll get used to doing this. It will be difficult though. So there's a continuous administration 1 year, there may be toxicities. We don't know the long-term toxicities as yet. And when the patient is re-challenged with IO later when he progresses, some patients will progress or everybody will not get cured actually. So this is going to be a problem. And some open questions for Dr. Manish and as well as all the audience. So following CRT and surgery, what are you going to do? Following surgery, somebody gets a CCRT and gets a surgery done, what is going to be the protocol? Following sequential CT and RT, we follow that so commonly. We do it for our frail patients. Many patients don't get CCRT. What are we going to do for that subset of patients? And somebody who has asymptomatic pulmonary infiltrates following CCRT, a common situation. How are you going to start IO? And somebody who's PDL1 negative, EGFR mutation positive, I don't know the answer yet. So we will need to test for biomarkers. Now, the biomarkers will be done in this setting as well, and they will be important. So we need to really understand and dwell into the data more, and probably there is still time to call it a day and say that everybody post CCRT is going to get IO. consolidation. Thank you.
Thank you, Dr. Prashant, for taking up the challenge and speaking so well against the motion. Dr. Manish, your chance.
Yeah, thank you. So only one very important thing. So we know that radiotherapy modulates the PD-1, PD-L1 status. And so those who are deemed negative, perhaps that's the reason the curve is still separating so well. And looking at that small subset may not really tell us what's happening with the PD-L1 negative population. And moreover, we are looking at a small biopsy about PD-L1. And the last point, which is the most important point, is the test of heterogeneity. So whenever you look at a subset analysis, you can't really draw very robust conclusions because you have to look at the test of interaction. And the test of interaction, whenever you look at a smaller subset, it actually becomes redundant. So I think the conclusion have to be drawn very carefully when we look at a smaller subset, and we cannot deny the benefit just based on cost. And this is a scientific forum, so we are not really discussing cost. Cost is definitely an impediment, and I think that message should go very clear to the drug companies. But I think it's definitely a path-breaking results, and it's definitely very, very practice-changing.
Thank you, Dr. Manish, and thank you, both of you. Any comments? Yes, Dr. Vaid, sir?
I think I compliment both the speakers, Manish and Prashant, both. It was an excellent debate. Congratulations to both of you. Thank you so much.
Yes, and I fully endorse that. It was really exciting and very informative.
Comment here, Jyoti.
Yes.
Jyoti, can I make a comment?
Yes, sir, please.
Manish and Prashant, great debate, but let me add on something, Manish.
Yes, sir.
Pharmacoeconomics is science. It is just not the question of cost. It is a science. Evidence-based medicine is based just not on randomized clinical trials. It is based on patients' preferences, availability of resources, and expertise. Please keep that in mind. That's David Sackett's statement. And let me just point out very clearly, the test of heterogeneity is more required when you look at a bigger data which is heterogeneous. Right?
Yes.
Thank you, sir, for that comment. And in fact, I now have the pleasure of inviting Dr. G S Bhattacharyya, a very eminent medical oncologist from Kolkata. We all know him. He is currently a senior consultant medical oncologist at Fortis Hospital, Kolkata. And sir will be talking about new frontiers in treatment of small cell lung cancer. A lot of action happening now in small cell lung cancer as well. So let's see what sir has to share with us. Welcome, sir.
Okay. I don't seem to be moving my slides well. Am I seen, please? Hello?
Yes, sir. Seen and audible both.
My slides?
Yes, sir.
Okay. So thanks a lot, Ashok, and let me say congratulations for the lovely book that you have been editor-in-chief of. And it's always great to be actually talking about all these lovely youngsters who have been doing a very good job. So let me tell you, with all these exciting things that has taken place in non-small cell lung cancer, in small cell lung cancer on today's date, actually, we are making progresses. We didn't have much of a progress at all. But in this period, we actually are moving through. And what's moved through with all this is basically our use of immunotherapy. So before I start, let me point out to you, very early small cell lung cancer surgery can be used and it may be curative. In patients who are actually having limited stage disease, the therapy, basically a standard of care today in good performance status, is concurrent CT-RT. And that is actually, we would also offer PCI to them after a reasonable period of time. In a metastatic disease, we would say that we would give 4 cycles of chemotherapy of etoposide cisplatin or carboplatin. On today's date, I think immunotherapy is there. That's what I would be talking mainly. And any patient in good relative state, even in metastatic disease with good control, should receive PCI. Second line therapy has been topotecan till date, but we'll see what's new right now as we move along. Extensive stage, as I said, is basically the use of platinum-based chemotherapies, platinum or etoposide. or platinum combined with irinotecan. The United States does not believe in irinotecan. Europe does not believe in irinotecan, but the Far East Asia does. And of course, there is a question of using PCI when the symptomatic brain metastasis is there, or when we want to prophylactically prevent it, we do use that after a patient is in good control. Thoracic artery only if you get a good control, basically. So use of etoposide and cisplatin was a main treatment base till 2019. 19 randomized trials, 4,000 patients, and what we did see was basically a benefit. Test of heterogeneity telling us that the benefit was round about 3 months when we use this as a chemotherapy. So when I look at the whole picture today, and I have started looking at it, we see that in between last year and this year, there has been majorly 5 new indications for using new drugs. The first line therapy has changed. Now we have the durvalumab and atezolizumab to be used. Second line, third line, I'll come back later. You can see on this slide what the FDA approval, I just wanted to keep it in mind to you all, is lurbinectedin, which was just approved in the month of June, and Pembro also in the month of June for unresectable tumor with high mutational grades. So coming into the first line therapy of using durvalumab or atezolizumab, these were major trials, and if I look at it, there have been actually 5 major trials, of which 3 are randomized, 2 are non-randomized, and if you look across, whether we were using durvalumab or we were using atezolizumab, we had an improvement in progression-free survival. And the median overall survival also came around a year's time. Roughly anywhere between 45 to 50% patients were alive at the end of 12 months. Around 1/5, 20% were alive at the end of 2 years. And the hazard ratios, both for the performance, in the PFS and the overall survival, did show a 30% benefit with a good confidence interval. This is where we first had in 2019, 27 June, AstraZeneca saying that the Caspian trial actually was positive, so we could actually have a new data, and that's how we move forward. So I'll start first with IMpower 133. This is the atezolizumab trial, which is a combination of carboplatin with etoposide, and maintenance of atezolizumab was maintained. These are patients who also had brain metastasis, which was permitted. And then at the endpoints for overall survival and investigated performance PFS, and the key endpoints were objective responses and duration and safety of the drug. Published in 2018 in November, first presented in ESMO. And as we see that there was a median progression-free survival improvement of close to 1.1 months on the MPS, statistically significant at 14 months follow-up. And the median time to overall survival showed a 3 months survival benefit. This became the new standard of care if one would look at it in 2018 after the publication. A warning here. Please remember that this particular article, if one goes into the proper look at subgroup analysis, you would suddenly see that it seems that in males, there is something not working that well. In performance status, 0. Again, we have some issues coming up. Brain metastasis is a questionable benefit there. Surprisingly for TMB, it seems if you're less than 10 or if you're more than 16, it seems to have an issue. Are we to take this well? This is a subgroup analysis, which is in the supplement of the paper. So I would like you to check it out, although this is an approved indication. We have the Caspian Data, which is the use of durvalumab. There were 3 arms to this study: durvalumab with etoposide, followed by maintenance durvalumab, cisplatin etoposide 4 to 6 cycles, followed by PCI, or durvalumab with tremelimumab with etoposide and cisplatin, followed by maintenance durvalumab. Endpoint overall survival. Secondary endpoints PFS, overall response rate, safety, and PROs. This was important because the PRO for the first time was being looked at in a trial in small cell lung cancer, where patient-reported outcomes are going to tell us how did the drug behave, which was important. So we would see that at the overall survival, there is a 13 months benefit, 3 months benefit actually, and this benefit is maintained. I would rather come to the tail of the curve and tell you all that if you're watching carefully at the end of 2 years, you have around 1/5 of patients who are still alive in extensive disease. This was not seen before. While in the control arm, it comes down to something like just 8%. This is just putting it in a different format and telling you what's available and looking at the overall response rates that was there. This was the other standard of first-line care which came up. Comparing both of them in one slide, one would see there's not much to choose when you are comparing both the slides, and they look to be same as we see, including the presentation that came up in ASCO 2020. So first line, till 1985, it was cisplatin etoposide when I started my career. Carboplatin etoposide is what was in between of my career. And now when I'm actually possibly trying to look away from things, as we see immunotherapy in both coming up in the form of eculizumab and durvalumab that has been approved by the FDA. Coming into second line, on June 15th, there was an accelerated approval of a drug called lorbrigidine. I will come to this drug and talk to you all because this drug actually interests me. We also had at this given point of time the approval of pembrolizumab for adult patients if the tumor mutational burden was greater than 10 by an FDA-approved test if it was done and if there was no alternate treatment. So that's all the trials, and if you look carefully, we would see that both pembro and the use of nivo in second line seem to have an impact. And if you watch, there was also a chance of using it without chemotherapy. So if I look at it in the third line beyond that, and I look at the pembro or the use of nivo, the checkmate 30032 or the keynote, I would see that responses rates were between 13 to 16% in both the studies. They did reasonably well for a period of almost 5 to 6 months, median overall survival. So we have the immunotherapy approved in the third line of these drugs. In fact, we can use the TMB and see whether we can combine two immunocheckpoints inhibitors. And if we look at high TMBs, the use of nivolumab and ipilimumab actually gives you a much higher benefit than when you're using single arm nivolumab, or if you're doing it in the lower groups basically. So late online nivolumab approved for third line, pembro approved for third line, as we have just saw. So just to fill this gaps in, till 1992 we had single drug irinotecan and docetaxel, although used even by the NCCN was not FDA approved. Topotecan IV was approved in 96. Paclitaxel was approved by NCCN again, but that's not standard of care. Topotecan oral drug in 2007. And now we have suggestions of temozolomide, and of course, as I just showed you, nivolumab and ipilimumab, and we have nivolumab approved in 2018 for third line. What happened at this year's ASCO? Quickly, we go through it quickly and see that pembro versus placebo in etoposide with platinum. This was basically a similar trial of what durvalumab did or what atezolizumab did. And what we do see is that there is a definite progression-free survival and overall survival benefit. So it seems to tell us, although the overall survival was superior in pembro, statistically not significant, but it seems that pembro did do reasonably well. And in my opinion, I would feel it does support the use of pembro upfront. You come down to the nivolumab data, it is similar to the pembro data, and it can be used. Coming to a drug that Moderator did, which I wanted to talk about small cell lung cancer in second line setting. This is a first in class drug. It's actually a transcription inhibitor, and it prevents a promoter from working, and that prevents actually IL-6 and VEGF working up. We have a success drug in the second line, while the Atlantis trial is there. This is now available for limited approval by the FDA and approved. It binds to the guanine cytosine-rich regulatory areas. It prevents binding of transcription factors and then microenvironmentally changes the drug. New in class, new drug, which is moving very fast. And what does the data look like? If I compare with topotecan, amberubicin, chemotherapy, nivolumab, I would see the response rates are better than even immunotherapy. The median progression-free survival is 3.9 months versus nivolumab. Median survival time is also better, and specifically if it is in sensitive disease. Accelerated approval was made, and the recommended dose is 3.2 milligram per meter square. Coral and basket trials actually proved what I just said, and this is what it is. Yes, there are side effects, but they can be taken. Mainly, please remember, neutropenia and anemia are two major side effects, but they are less than topotecan. Where do we go next? The next thing is we need more therapies to come in. biomarkers that will tell us where it works best, and new agents under consideration. So just to tell you, if on your right-hand corner, as you can see, immunology is there with PD-1, PD-L1, CTL4, and CD47. We have the Aurora kinase stuff. We have the DNA repair from the PARP, the epigenetic methods, and the development regular pathway because of its neuroendocrine dysfunctions, which we have is the DLL3 or the Notch pathway. So just to tell you that PARP inhibitors do work, and talazubam has some good data at preclinical level and at clinical level that it can eliminate small cell lung cancer. Same thing holds true for olaparib. I want you to concentrate on the olaparib with temozolomide. There is data telling us it works in heavily pre-treatmented patients, and as we can see that there are patients who did reasonably well. Response rates are around 23% in temozolomide combined with olaparib. Response rate in platinum refractory is 13%. In brain mets, 40% actually respond. Can we tell who's PARP sensitive? We can use a single nucleotide study of doing an SNF11 and get this up. Aurora kinase data is moving in fast, and we know that there are a subset when it works well. In sensitive patients in 55, it gives a good person, can give a good disease control. In refractory, in about 50%. Harnessing the neuroendocrine therapy, this is something important because these are basically for the pulmonary neuroendocrine tumors, and they seem to be again doing pretty well. I just wanted to tell you something that tiraliciclib, which is a CDK4/6 inhibitor, has just received its priority review in small cell lung cancer. For the first time, we are now seeing a drug which can actually prevent myelosuppression. In fact, it decreases it by 67%. It decreases neutropenia by 51%. GCSF dose comes down by 80%. So here now we have a new drug that's trying to make chemotherapy more successful. And since we can actually deliver more chemotherapy in this particular situation, we are moving into an area where chemotherapy can be a better effect. So before I end up, let me just tell you two problematic areas which are there, which even the GO2 lung cancer registry tells us if we are using in small cell lung cancer is one, the side effect management, two, emotional issues, financial distress and transportation is a major problem. AE side effects are there. I'm sure we are more aware of them. I would always request patients should be a part of our partners in deciding what we do, and that's how we move forward. So I will say, if there is a question and if you have time, I'm ready to take it. Thank you.
Thank you, Dr. Bhattacharya, for that very extensive lecture. And we really look forward to a lot many new drugs getting approval even in small cell lung cancer. Any burning questions? Take one because of paucity of time.
Can I ask GS a question, Jyoti, if you permit?
Yes, sir. Please.
So, GS, very nice talk. Thank you. My question to you is, why is PD-L1 expression not important in choosing an immuno-oncology drug in small cell? And why is it important in non-small cell?
Hemant, in small cell lung cancer, in the upfront when it's combined with chemotherapy, right? It is not being done. But in the second line and third line, it has to be PD-L1 greater than 1%. That's one. In the upfront use with the chemotherapy in small cell is not required, because what we see basically is that they actually chemotherapy acts as an immune sensitizer, which occurs with this. This is something that is a mechanism which we know that all immunotherapy is just not PD-L1 and PD-1. There's much more to it than what we know of right now. So we need a proper answer, but the answer seems that chemotherapy acts synergistically and so enhances the impact of immunotherapy. You can always get back to me and say that maintenance immunotherapy without giving it in the induction never worked, but because you give it in induction, they work together. For second line and third line, you need a 1% PD-L1, at least for pembro and nablo.
Thank you, sir. So we move on to the last session for today. And this session is also sponsored by AstraZeneca. And may I invite Dr. Ullas Batra, a senior consultant medical oncologist from Rajiv Gandhi Cancer Institute. He is also the chief of thoracic oncology there. And may I also request him to stick to time. I know we are being a bit unfair to him by cutting short his duration of his session by 5 minutes or so. So Dr. Ullas, please go ahead and invite your panelists.
Sure. Thanks, Dr. Jyoti. Thanks, Dr. Vaid, for getting me over here. And I realize I'm the one who is standing or sitting between you and the dinner. So how much time do I have? 15 minutes?
No, you can take 20.
Okay, fantastic.
20
Fantastic.
Minutes. Yes.
Okay. So my panelists for today are Dr. Pankaj, Piyush, Sushant, Chandru, Sajjan, Dr. Vineet Govind Gupta, Dr. Darling. Dr. Darling, I really love your name. Sometimes I'm going to make good use of your name. Dr. Abhishek Raj, Dr. Shyam Singh Best. Okay. So I think are my slides visible? Am I audible?
Yes, sir.
Yes.
Okay, fantastic. So let's start the fun. So we will start with a normal case. We have a 60-year-old female who comes with cough and breathlessness for 2 months. A PET scan was done, which showed a right lung mass with bilateral permeate nodules, multiple liver, bony mets, ECOG PS1. Lab parameters normal. Biopsy from lung mass was suggestive of adenocarcinoma. So what next? I'll start with Dr. Shyam. So what are biomarkers normal standard questions, What are biomarkers you send for and what sequence? Dr. Shyam Singh Best.
Hello. Yeah, for case of adenocarcinoma, we will go for EGFR, AL, ROS, PDL1.
Fantastic. So EGFR, AL, ROS, and PDL1. So let's say this is a Novartis symposium. It is not an AstraZeneca symposium. Then what would you do?
The same sequence. I will not change the sequence.
So you will. So no wonder Novartis is not participating right now. Okay. Sajjan?
So for me, if possible, to go for a lung dedicated panel. Otherwise, EGFR, ALK, ROS1, and PDL1 and BRAF V600E.
Sajjan, you're driving back home. You can park somewhere.
It's okay.
Okay. So when you say, Sajjan, a dedicated lung panel, what do you exactly mean by that?
So normally, these are the genes which I would always be like to get them done from NGS panel. If our institute is there, which is able to do them in a reasonable time period, like 10 days to 14 days, and the patient is not very symptomatic, so that I'm able to have all these tests before I'm able to start my treatment. But if that panel is not available, then these tests can be done individually also.
Okay. Sushant, we haven't met for a long time now, Sushant. So if I have to ask you.
Yeah.
So yes, Sushant, long time we have not met each other,
yes,
right?
Yes.
Tell me. So what do you will send a sequential manner? You would want to send in a broad panel pathway. What would you want to do?
I would like to send all of them together if possible, if I am confident enough for a standardized lab which can do the justice to the tissue and the cost of the patient also.
Okay. Standardized lab, justice to the tissue, justice to the patient, justice to the doctor. Okay. All politically correct answers. Okay. I'm going to catch you guys on this. Okay. So Dr. Vineet, NGS, yes or no? Do you routinely order, and how many patients of lung cancer, or will you order, and what prevents you from ordering that? Dr. Vineet Govind.
There, I think. We don't have Dr. Vineet with us.
Fantastic. Dr. Piyush?
Yeah. Not all patients, I do not send NGS. Hotspot mutations, yes, as was mentioned earlier, the panel of hotspot mutations, Sajjan mentioned. But not every patient for NGS, probably in the second line, not
okay.
upfront.
So not in the upfront. Okay. So Dr. Abhishek is there?
Yes, sir. I'm here.
Okay, Abhishek. What's your take?
So, sir, lung-directed NGS I am testing upfront in patients of adenocarcinoma histology, and in or if the patient has adenosquamous carcinoma, sir.
Okay, fantastic. So, Pankaj, I think you are the last man standing over here. So, I'll ask you two questions over here. One question is, do we order NGS testing upfront in RGCI? If yes, why? If no, why? And if, let's say, tomorrow you get the lung unit in Rajiv Gandhi, what would you want?
No, that's not politically correct.
That's not politically correct. Okay. So, I am telling you. Okay, what would you want?
I tell you what, now actually we have to see whether the patient can spend so much that if I get some peculiar mutation from NGS, whether the patient be afford.
Pankaj, let's come to that. So what is the cost, what is the time, and what are the genes that you want? So what is the reasonable cost for you?
Sir, NGS, I think the reasonable cost should be somewhere around 25 to 30,000.
Okay.
But timing should be, for me, it should be a week, the same time when if you ask me what is the desired time. But recently I tested a patient for EGFR, Gross, MET, and all these tests were done. And then patient asked for more. So more than again, after this NGS was ordered, HER2 turned out to be positive. Now there's a lot of confusion. So NGS opens a bag of worms, I should say. It will give some suggestion for which you do not have any answer. Then the patient will ask, sir, test kyun karwaya tha? So I think when we order an NGS, we have to tell what we are looking for and what we will not look at. Okay. And then talk about NGS.
Okay.
Along with PDL1.
Dr. Chandru, are you here? Chandru is here. So Chandru, yes or no? So suppose you get a lung unit at RGCI tomorrow. NGS yes or NGS no? So first of all, I am not the one who's offering any of these jobs, okay? So Chandru, tell me, tomorrow if you're in charge of the lung unit anywhere, you are a director at Akash, so tell me if you have to say yes or no.
I don't
Chandru
think
he's going to join.
He's going to join RGCI only. Okay. So Shant?
Ulas, I have a comment here.
Sir.
You have already offered this post to of them,
So I have applied for a job in Medanta.
So don't let all these secrets out. Okay. Thank you.
Okay, sir. Fantastic, sir. Okay. So my take on NGS actually is, Sajjan spoke about the lung-directed panel. So my take on this is sooner or later, we will have to go towards the NGS way. The one thing which is prohibiting us from going into the NGS way is the time that it takes for the reports to come. Probably if Kumar Prabhash was there and people like him who have been doing a lot of work in NGS, they say if you put all your samples into NGS, probably your turnaround time, as Pankaj very rightly said, would come to less than 7 days or 10 days. And then we can actually have a lot of other mutations, rare mutations which can be detected. So at present, we are not offering NGS to everyone, but probably in the near future, we are going to, in year, 2 year or 3 years time, it is going to, NGS is going to rule the roost actually. And for me, personally, the more the merrier actually, as far as the NGS is concerned. So any particular challenges, Dr. Piyush, that you have faced in the COVID era?
I think the lung biopsy primarily was a challenge during the earlier months, May, June, where the pulmonologists were apprehensive, as well as even the interventional radiologists wanted COVID testing done because of the aerosol being released to CT-guided biopsy. So those were the things. Of course, these were the major.
So when was the COVID testing which was required? Dr. Abhishek, any particular testing that you faced?
Sir, so I'm working Fortis, sir. So here our molecular lab is outsourced. Like the SRL test goes to Mumbai. So when the COVID era just began and the lockdown thing was going on, so there was a lot of problem sending the samples to Mumbai and then tracing the reports back. So in fact, I had to wait almost 4 weeks for one of the NGS panels reports to come. And of course, as sir mentioned, that there was also an apprehension about doing biopsy by the pulmonologist. That is always there.
Okay. So Piyush, what about liquid biopsy? Where do you think you would place liquid biopsy in the context of a NSCLC?
So liquid biopsy, yes, if you have a diagnosis of carcinoma, then probably yes. But then again, it is not something which is standardized, validated. Not many labs are doing it. It is only few labs. Again, TAT is more. You have cost issues. So those factors have to be taken into account. So liquid biopsy, especially post-COVID, the recession is a challenge.
Okay. So right now, probably everybody is not using liquid biopsy, but I think it's a fantastic, again, futuristic way of looking at the EGFR mutations, because if you have more samples and if you have an in-house lab, you can actually get the reports very, very, very early actually from there. So now let's come down to our patient. So our patient had a EGFR deletion 19 present, ALK was negative by IHC, ROS was negative by IHC, and the PDL1 was 90%. So Dr. Shyam Singh Bisht, what would you do? And imagine it's a AstraZeneca or a AstraZeneca bar MSG bar symposium. So you have PDL1 which is 90%, and if you have a EGFR del 19%.
Dr. Ulas,
Ji.
sorry to interrupt. Dr. Shyam Singh Bisht is a radiation oncologist.
Okay, fantastic.
You could, direct.
So I'll ask him the other questions. Fantastic, fantastic. So can I come to Pankaj, or Dr. Darling is there? Dr. Darling?
Yeah. Yes, sir.
Hi.
Sir.
So tell me.
Sir, I will focus on EGFR positivity, and I will prefer oral therapy, especially in this COVID era. So I'll offer osimertinib if patient can afford. Otherwise, first line, gefitinib or erlotinib.
Okay. So my question to all of you, and that is one question which is going to be the two more important questions that I'm going to ask. One is, do you think the treatment of EGFR mutant non-small cell lung cancer with first generation TKIs is suboptimal in 2020? So Dr. Darling, do you think if I give gefitinib, you think it's suboptimal?
I will not say it is suboptimal, but there are definitely.
So if I give you the, let us say you're offered the lung unit in RGCI, what would be your protocol?
Sir, if it goes by my choice, I will give osimertinib first.
Okay, you will give osimertinib to everyone. Okay.
Yes.
So Pankaj, what is your answer to this?
Sir, I think this is suboptimal in 2020 when we have OS data with other drugs, namely osimertinib and docomertinib. However, what we use is anyone's choice, but definitely this will be suboptimal.
Okay. Piyush?
Yeah, so I agree with Pankaj that if the patient can really afford osimertinib, gefitinib alone would be suboptimal for sure. But for those who are not able to afford osimertinib, then what to do is the real question. So in that case,
so we will come to that later. So we will come to that later. Right now, but only let's say some person comes to me and we give either gefitinib or erlotinib. You think that maybe I could have done a better job?
I mean, financially we have to look obviously. I usually now start with chemotherapy and wait for the mutation to come. Every new chemotherapy, even if it is a EGFR and patient is not able to afford osimertinib.
Okay.
With the first generation.
Prashant?
I would like to offer osimertinib and proceed.
Okay. Sajjan?
Yes, I agree. I think most of us agree that osimertinib will be our first choice, and we will like to reserve PDL1 marker for later lines.
Okay, so I think the first generation is probably become like Shah Rukh Khan of this right now, and it is actually not working anymore. You need somebody to really supplement that.
So that has become Sushant, sir.
Sushant is the bad
Right, sorry.
Okay, so by and large, this is what is said that EGFR first and second generation have shown an increase in PFS, but there is no improvement in OS. So we will again now start with let's say Dr. Darling and Dr. Abhishek after that. So among all these things, if cost is a concern, what was your choice? And if cost is not a concern, what's your choice? So Dr. Darling.
Yeah. So if cost is a concern, then first generation TKI, and if cost is not a concern, then third generation TKI.
Okay, fantastic. Dr. Abhishek?
So if cost is not a concern, definitely third generation TKI because of the improvement in OS as well as good CNS penetrability. And if cost is a concern, sir, I would probably choose TKI and chemotherapy based on the Tata Memorial study that was came out recently, sir.
Fantastic. Fair enough. I got it. Dr. Sajjan?
I think I agree with the previous one that if cost is not an issue, then definitely third generation. But then I'm also very happy to use a combination of first generation TKI with chemotherapy in a less affordable patient.
So in the two people are going for, I mean, everybody's going for osimertinib first line, but if cost is an issue, chemo and TKI. Okay. Sushant? This is like this is one girl with so many suitors now coming up. EGFR mutant non-small cell lung cancer has become like this. Okay. Sushant?
Sir, osimertinib.
If patient cannot afford?
Geftinib, sir.
Okay. So 2 people for first generation TKI, 2 people for first generation TKI plus chemotherapy. Fantastic. Piyush?
Yeah, I mentioned that if patient cannot afford chemotherapy and first generation TKI regime.
Okay. And so 3 in 2. Okay. Pankaj, you are the last one.
Sir, if patient can
on your shoulder hinges the entire discussion about this girl, where she's going.
So she'll go with you.
It hinges on your next promotion, Pankaj.
Okay.
Sir, if the patient can afford, obviously osimertinib. If patient cannot afford, I am happy with single agent TKI rather than combination.
So by and large, the public seems to be divided between EGFR. I mean, so if somebody can afford, definitely you want to go it with chemotherapy. So in addition, you want to give osimertinib. So in addition to all these factors, is there any other factor that we think about? The cost. I think osimertinib by and large scores about everything except for the cost. That is one thing which is really coming on over there, and that was the OS data which was there. So let me just go away with this, and since everybody knows this data, forget about that. Now we have a radiation oncologist also over here, and in my last 5 minutes, I would like to ask you guys something about NSCLC with brain mets. So Pankaj, I'll come to you again. Do you routinely do MRI brain in all the patients of stage 4 NSCLC?
Sir, now yes, we have started to.
Now yes, okay, fantastic. Anybody else who is not doing?
No, sir.
You know that you're not doing, or know that you're doing?
Not doing, not in all patients.
Fantastic. Sushant?
So not doing in all patients.
Not in all patients. Piyush?
Yeah, only the PET CT. Not
the
doing
PET CT, not really. Dr. Sajjan?
Only PET CT, sir, in asymptomatic patients.
Okay. So Dr. Shyam Singh, sir, what is your take? Should we do MRI brain in all the people?
Yeah, on all stage 3, we should go for at least stage 3.
So not stage 3, stage 4, sir. Stage 4 asymptomatic.
Yeah. So we should go, even in asymptomatic, we should go for MRI brain.
So the NCCN guidelines actually say that you should be going into that. But let's just come to these 4 scenarios now. So Pankaj, you said yes, we are doing. So tell me, these are the 4 scenarios. So let us say, as you said in the last one, no patient said, "Ki sir, aapne karaya hi kyun?" So now tell me, if you have the option number 2, so patient is EGFR del 19 mutant, EGFR mutant, and patient has got multiple small mets asymptomatic. What would you do?
Sir, possibly if the patient is being put on osimertinib, I will not be doing anything. But the intention of doing the MRI in my case is that I need to know what all sites are there before I start therapy. If after say 3 months or 4 months patient has some seizures, someone else gets an MRI done, then it will be a new information and we will think that the probably drug has stopped working and we'll be like pushing, maybe we need the change of therapy or we'll be scratching our heads. So if we had the baseline MRI, then probably we'll be knowing that it's the stable disease or it's just a seizure or it's the progressive disease. So that was the main intention rather than focusing on the treatment.
Okay. So let's go to Dr. Shyam Singh. Sir, you have all these 4 scenarios. You have an isolated CNS metastatic lesion which is asymptomatic.
Right.
And let's say in all these 4 scenarios, somebody can afford osimertinib. Let's just say that.
Right.
So you have an asymptomatic person who has a single isolated CNS metastatic lesion.
Yeah.
Send it to you, or we just start osimertinib?
Osimertinib plus radiosurgery. If there is a single or limited metastasis, whether it is asymptomatic because
do you want to start on osimertinib, let the disease come down and then do, or you want to start with radiosurgery and then give osimertinib?
I would like to go for radiosurgery because radiosurgery followed by osimertinib, because in radiosurgery you won't be wasting much of time, just 2 to 3 days of time. And as the data has shown, this osimertinib data, it improves the overall, improves the detection of new metastasis. That means decreases the chances of having a new metastasis in the brain. This is the same role which is being played by a whole brain. So now the era of whole brain has gone.
Dr. Shyam, 1 second. So all my panelists agree that for an isolated CNS metastatic lesion, asymptomatic local treatment for the brain followed by osimertinib. Is it right? Anybody has a different point?
Not really.
I would probably go for just osimertinib if it is asymptomatic.
The medical oncologists still want to go for the pill. Dr. Sham, convince them.
Yeah, in case if it is a non-measurable metastasis, like
it's a good 2 centimeter lesion.
Yeah, I think definitely, because at some point of even if you see the latest data regarding the rate of complete response of the with osimertinib in the CNS metastasis measurable, they are around 21%. And if you just go to the radiosurgery series, with the radiosurgery, a single sitting of radiosurgery, there may be up 65% chances of having a complete resolution.
Dr. Sham, so osimertinib does cross a blood-brain barrier.
Yeah, I know. Yeah, I agree.
And the response rate is to the tune of 60 to 70%. I may be the moderator, but I am a medical oncologist also, so I cannot.
Yeah, agree. It is a 61% response, but complete response. That means complete resolution.
Complete response.
If you just go into the data, it's complete resolution, just 21%. The response in case of measurable.
So to all the medical oncologists, does it make a difference whether the patient is responding completely or not, as long as patient is asymptomatic, right?
No.
Piyush?
No, actually, that point that osimertinib crosses blood-brain barrier is quite convincing for us to start it upfront. But what Dr. Sham is also trying to say is not wrong, that it's a targeted therapy that he's also using. He's also using a targeted, it's a SRS, is a 1-day therapy or 2-day therapy. So, I mean, and it is not decreasing the cognition. So considering that, they are also using targeted therapy, and probably if the metastasis is in temporal lobe, which is probably the site is also important, the perilesional edema, the lobe. So I think so. It is a multidisciplinary.
I think this is a question to the organizers. You know, Dr. Jyoti and Dr. Vaid, you should have this as a debate, maybe in the next session that we are going to have. Last one, Dr. Sham, the second one.
I would like to add one thing. Like there are already I think 2 trials are going on which are comparing osimertinib plus SRS versus osimertinib alone.
So till that time, we'll have the debate.
Yeah.
Okay. The second one. So I think there should be more there should be more agreement on that. If somebody's got multiple small mets, which will not be dealt with SRS, which are asymptomatic. So Dr. Sham.
Yeah, if they are multiple means limited. If they are like maybe 4 to 5 metastases, if they are more than, I think, rather than giving a whole wind reduction, I would like to prefer for osimertinib.
So I think all my medical oncology friends
agree.
Yes.
Agree. Osimertinib, fantastic. Symptomatic CNS mets.
In case of symptomatic CNS metastasis, if it is like size is large, maybe more than 4 centimeters, having a perilesional edema, midline shift near to critical structures, in those cases more than 4 centimeters, surgery, I think a resection would be preferred. If it is symptomatic small with a seizure, then a radiosurgery would be preferred.
So the entire, I think this is, I think I'm getting a call from the organizer that I need to wind it up. So the entire purpose of having this 4 kind of scenarios was that, you know, CNS mets is not one disease. We need to have a look at how many numbers, patients symptomatic or non-symptomatic, and can SRS be offered, can whole brain RT be offered, and definitely we should try and we should not club CNS disease into one disease, and we should personalize therapy for all of them. So with this, I think this is my final slide. And that is basically, if it was not for the great variability among individuals, medicine might as well be a science and not an art. And with this, I thank all. My last comment is the offer is not valid now since you have not taken it. So the lung unit and RGCA belongs to me right now. Thank you.
Ulas, before you sign off, one observation that throughout the discussion, I was a little surprised that none of the panelists actually opted for a second generation TKI.
Probably it was not okay. I think we can discuss that sometime later, sir.
Thank you so much.
Although I would agree that with the data of Geotag and the data of Archer study, sequential therapy also is a good approach. But you need a young, fit individual who is very well motivated enough for the sequential therapy. So in my mind, that is also a very good option. But
thank you.
Back to you, sir.
Thank you for helping us stick to time and be punctual. I now request Dr. Ashok Vaid Chairman, Department of Medical Oncology, to please give us concluding remarks for the day.
So, thank you so much for the wonderful discussions, and I have my special thanks to all the faculty, starting with Amit and followed by Dr. Hemant, and the wonderful debate Manish and Prashant had, and then over to G S Bhattacharyya, and of course, last to you for that conduct of that wonderful panel discussion, and all the panelists who contributed so very well, and Dr. Jyoti for the wonderful conduct of this second day symposium. And ladies and gentlemen, we thank our sponsors AstraZeneca and Shilpa Pharmaceuticals for sponsoring the program of this evening. Stay safe, take care, good night, and hope to see you tomorrow again. We have a very exciting program tomorrow again on breast cancer. As we did today, we had innovative ideas and innovative questions. Similarly, we would be replicating the idea tomorrow for breast cancer as well. Do come back and hope to see you tomorrow again. Good night, take care. Thank you once again.
Stay safe.
Thank you, sir.